Good morning, everyone, and thanks for joining the EDC Coffee Chat, Coffee with Colleen. Thank you for joining us, and we are really excited about having Eric Lewis, the Chief Financial Officer of Washington State Hospital Association and the President of Washington State Healthcare Services. I think I might have gotten that wrong. He'll correct me though. Before Eric kicks it off, I'd like to ask everyone to put themselves on mute. If you have any questions, raise your hand, or you can put your question in the chat. And also, of course, Eric was the CEO of Olympic Medical Center for 14 years. That you guys all probably know that. But he's a hometown guy in Sequim, and we're lucky to have him advocating for healthcare issues at the state level, but he obviously knows the challenges we face, particularly on the Olympic Peninsula at a rural sole source hospital. So again, thank you, Eric, for joining us and all the work that you do. And with that, I'll let you take it away.
Okay, well, good morning, everybody. It is great to be here. I spent a total of 22 years at Olympic Medical Center, and it was really great to be part of that team. I enjoyed that work. First 8 years, I was the CFO. That might have been I enjoyed that job. CEO job was very rewarding, and we had a great team there, but it was certainly challenging. My background is public accounting, and I became a CPA, and I used to have brown hair, believe it or not. Then I got into healthcare, and it slowly changed colors. But as the WSHA CFO, I actually work from Sequim in my home. I do most of it remote. I go to Seattle on Thursdays, and sometimes I go to Olympia and visit members. But I mainly work on advocacy, Medicaid funding, financial challenges of hospitals. I took my job in February of 2020, not really knowing what I was getting myself into, but it's been quite a journey for hospitals the last 3 years. Definitely the most challenging times I've ever seen in healthcare. But I'm a big fan of the EDC. I really think you guys are doing important work, and I'm thankful for it. I think Colleen and Lori, the EDC board members. The work you're doing is critical, and I was on the EDC, I think, for 14 years. I was on the board for a long time, and I don't think the EDC's ever been more effective and better. So it's keep up the hard work, because it's important for our community. So I'm going to share my screen. Okay, that's always the most stressful part of the day when you're sharing. Does it work? You guys can see that, right? Okay. I just want to talk a little bit about WSHA, the Wash State Hospital Association. We have 82 employees, a $17 million budget, and we have 6 legal entities. WSHA itself is a nonprofit association, 501c6. We also have a for-profit sub called Washington Hospital Services. We have a political action committee and 3 self-insurance groups for workers' comp and unemployment services. But our mission is really to advocate for and provide value to members in achieving their missions. And our vision is to be the trusted voice and indispensable resource that leads, challenges, and assists hospitals and health systems to improve the health of their communities they serve. And this is a map of Washington State, of all the hospitals in the state. You can see Port Angeles has Olympic Medical Center. I tried to get them to add Sequim, but they said no, it has to be only hospitals. But obviously Olympic Medical Center has a large Sequim campus. But the main thing I want to point out here is we represent all 113 hospitals in the state, which it's rare that a hospital association has every hospital in the state as members. But what makes up our members is pretty evenly split between rural and urban. There's 48 urban hospitals and 44 rural hospitals. Now, most of the rural hospitals, about 39 of them, are what's called critical access. That means they have 25 beds or less, and they have their cost reimbursed as defined by Medicare, Medicaid for most of their services, but not all their services. Olympic Medical Center is a unique rural hospital in that I think it has many more than 25 beds. I think about 67 or something in that range. And large rural hospitals face unique challenges, but with 44 rural hospitals, I just want to mention the interdependency between urban and rural hospitals. Rural hospitals really depend on, Forks Community Hospital, OMC, Jefferson Healthcare, really depend on being able to transfer critically ill patients quickly to urban hospitals like Swedish, Virginia Mason, St. Michael's. Those transfers need to happen quickly. And then the large urbans need to be able to transfer appropriate patients back to their community hospital. So I think when any piece of the hospital system is hurting, it affects the entire delivery system. And then if you look at the type of organizations, the largest type of hospital in the state of Washington is nonprofits, 501c3s. There's 53 nonprofit hospitals. The next biggest is 41, and that's public hospital districts. That's what Olympic Medical Center is, Jefferson Healthcare, and Forks Community Hospital are all public hospital districts. There's only 12 for-profits, which is really low compared to other states. Now I just want to talk a little bit about what WSHA does. And the biggest thing we do is government affairs. We do advocacy in Olympia and Washington, D.C. And we advocate for three things mainly: patient access to services, healthcare coverage and access is a big deal for our communities. We advocate for adequate reimbursement, which I would say today we don't have. And then reasonable regulations and laws. So we work with the American Hospital Association in DC, and we have an office in Olympia and spend a lot of time in Olympia. On safety and quality, all the hospitals in the state decided to work together over 20 years ago on quality and safety. So if one hospital finds something that improves the process to treat sepsis patients, they tell all the other hospitals. So all hospitals in Washington are trying to improve the safety and quality of the care they give. And it's kind of like, if Alaska Airlines found out a way to help prevent airplane crashes, they should tell all the other airlines. And that's what the hospital industry has done. A lot of great work improving safety over the last 20 some years. And then we do a lot with data, financial, volume, safety and quality data. And really the real power of WSHA is power and unity, all 113 hospitals working together. I'll just give an example on COVID. During the pandemic, there are various waves that filled up hospitals in various areas. And all the hospitals in the state agreed to level load, meaning we transfer patients across the state to make sure a patient who needed an ICU bed always got one, or needed that higher level of care. And there were thousands of patients transferred around the state. And the pandemic started in Kirkland and Bellevue. Seattle hospitals took the overflow, and then Seattle filled up and they moved patients to Everett and Olympia. And at times, Eastern Washington was full and hundreds of patients got airlifted into Seattle. And it really worked well because at the end of the day, Washington State had the fourth lowest death per thousand from COVID because all hospitals worked together. And in other states like New York and Texas, there were some hospitals that got overwhelmed, and hospitals, 10, 20 miles away did not take those patients. And it led to unfortunate outcomes. So I think the hospitals in Washington State have a unique positive working relationship. Is there a question in the chat?
Yes. I asked, what are some of the largest for-profit hospitals, and are they charging more than the nonprofits or the PhDs?
Yeah, the for-profits are primarily psych hospitals. Really, all the hospitals in Seattle area that you would think of, from Virginia Mason to Swedish, to University Medical Center, they're all nonprofits or governmental entities. I would say, I'm not sure if for-profits necessarily charge more. They have, a lot of them have stockholders, so they have quarterly results. So it's a little bit different than a nonprofit. But most of the nonprofits, the 12, are pretty small psych specialty hospitals. In the Tri-Cities, there's a couple of for-profit acute care hospitals, but most of the hospitals are either governmental or nonprofits that you would think of, the major ones.
Got it. Thank you.
Now we get to talk about numbers. This is a statewide income statement from 2022. It is all the acute care hospitals, or about 98% of the acute care hospitals. And 2022 was a uniquely challenging year, and it's continued into 23. You can see the revenues statewide were 30.7 billion, which was a 5% increase, which normally would be really good, but expenses went up 9% to 32.8 billion. But the big number to remember is statewide acute care hospitals lost 2.1 billion, which I'm not even sure what a billion is, but two with 9 digits afterwards is a lot of money, minus 7% margin. And this is 85% of hospitals lost money. And this has really never happened in my career, that this many hospitals at the same time lost this much money. And you can see 21 wasn't a great year, with hospitals lost 742 million, which is about a minus 3%. The other factors that happened in 2022 is, of course, the bond market. Bonds lost money because interest rates went up, stock market went down. So hospitals had investment losses of 920 million. And the COVID relief money finally ran out. There was $322 million of COVID relief. But in 21, it was almost 800 million, and kind of made hospitals whole in 2020 and 2021. But in 2022, the COVID money largely ran out. A few rural hospitals had a little bit of money left, but the urbans did not have any money. And I will say every urban hospital from Everett to Olympia had large financial losses in 2022. The urban hospitals actually did worse than the rural hospitals, which is very unusual. Why did the hospitals lose 2.1 billion from operations? And you can see the net loss was 2.7 billion. I know that the negative cash flow was quite dramatic in 2022, but the losses are really due to low Medicare, Medicaid reimbursement, workforce shortages. Inflation really impacted hospitals, and difficult to discharge patients, which I'll talk about in a later slide.
So Eric, how does it look in the first half of 2023?
We're just doing our survey right now. We think it's going to be slightly improved, but still very large losses. Everybody I've talked to, losses are still happening. There'll be hundreds and hundreds of millions of dollars of losses. I don't know exactly what it'll be. But it's certainly very challenging environment for hospitals right now. And I'll get into the reasons in more detail. Mm-hmm. But 2.7 billion of negative cash flow really reduced the cash reserves of hospitals across the state.
Mm-hmm. Is that typical in other states as well?
Yeah, this is a national problem. I think hospitals lost money across the nation. Many challenges, but I think Washington losses were a little bit bigger, mainly because we have lower Medicaid funding, and we have a larger difficult to discharge issue than most states. And I'll talk about that in a later slide. But Washington losses, I think, were a little bit larger than in some other states.
Thank you.
And then I just want to briefly mention, why did nonprofit and governmental hospitals need to make a small margin, 3 to 5%? The biggest reason is hospitals are very capital intensive. You have to buy very expensive buildings, equipment, technology, really to maintain standards of care. So when you see hospitals losing, $2.1 billion from operations across the state, they probably need to make $1 billion in order to invest in their capital needs. And they also need to make principal payments on their long-term debt. Hospitals across the state have about $10 billion of debt. They're kind of mortgages on their buildings. And those payments have to be made. Bankers really have no sense of humor when it comes to those payments. And then hospitals need to maintain their reserves for emergencies. Like when COVID hit, hospitals having some emergency funds to meet payroll was really important. And then money to start new services and spend on strategic and community priorities. But definitely hospitals need to make a small margin in order to continue to serve their communities over decades. Now I'm going to talk about Medicaid funding. Now Medicaid, of course, is for low-income individuals. State of Washington, if you make less than 138% of the federal poverty level, you can qualify for Medicaid. What's amazing is there are 2 million people in Washington state on Medicaid. About 25% of our population is currently on Medicaid. Now they're going to be doing some redeterminations, which they stopped during the pandemic. So we think by 2024, but there will be about 1.7 million Washingtonians on Medicaid. It's about 22% of the population. And Medicaid really pays low. It pays about 63% of costs statewide. So can you imagine a business model where you spend $1 on salaries and supplies and medications and things, and you get paid 63 cents? Not a very good business model. And if you compare Washington at 63 cents to California's at 84 cents, Colorado and Oregon are at 76. Alabama and Texas and Utah are actually higher, above $1.20. So those hospitals are actually making a profit off Medicaid, which is hard to imagine. The shortfall in Washington state in 2020, this is a little bit old data, was $1.5 billion. So hospitals across the state are basically subsidizing the Medicaid program. And I think it's definitely a challenge in rural communities like Olympic Medical Center. They serve a lot of Medicaid patients and get paid below their costs. Now I'm going to go to Medicare reimbursement. This is, of course, for everybody over 65, disabled, and with renal failure. Washington State is a low Medicare reimbursed state, and we're ranked 43rd, the 8th lowest reimbursement in the country. And this has to do with geographic variation. Washington State has low inpatient admissions relatively to the rest of the country, and high outpatient utilization, which pays less. You can see New Jersey and Texas, get about 106%. So it's a big difference. It's actually probably $1 billion statewide between what Washington gets paid and what Texas gets paid for taking care of. It's on a per person basis. So low Medicare and low Medicaid reimbursement in Washington is a challenge, and particularly for Olympic Medical Center, which is about 60% Medicare. Low Medicare funding is a big challenge because they're paying roughly 80 cents on the dollar of cost. So again, the business model of spending $1 on salaries and supplies and getting 80 cents is not very good. And then moving to commercial. Now, commercial is very costly. I'm not going to say it's not costly. And these are comparing state averages, so individual policies, can vary. But RAND, a national consulting firm, did a study comparing hospital reimbursement for commercial payment to Medicare rates. And what RAND found is Washington is 165%, which means that for every dollar Medicare pays in Washington, the average commercial would pay $1.65 for the same service. So that's relatively low, being ranked 48th. National average is 259%. You can see Oregon's at 270%, and California 297, and Colorado at 351%. So
Eric, how are these Medicare reimbursement rates established, and how are the commercial payment rates established?
Yeah, Medicare reimbursement rates are determined by Congress and the president's signature, and they've been built up over decades. But for prospective payment system hospitals like Olympic Medical Center, they get paid a fixed amount for inpatient called diagnostic related groupings, and for outpatient they get fixed payment levels. And these, you're basically, as a hospital, you take what Medicare gives you. You can try to advocate for adequate funding, but it's basically Medicare has their rates, and that's what you get. For commercial payers, it's a negotiation between the hospitals and the commercial payers. So that hospital does have some control over that. Certainly the way our system works, you have to get paid more for commercial to make up the government shortfalls. But it's a big challenge.
So Rebecca's asked, why does Medicare pay different rates to different states? You said Congress established that.
Yeah, back in the 80s, when Medicare used to be cost reimbursed to hospitals, and back in the 80s, they kind of locked in, they took whatever your costs were in the 80s and kind of locked you into payment rates, which have rolled forward for decades. But if you had low costs back in the 80s, you're still getting paid less. And Washington has always had a relatively cost-efficient delivery system. And geographic variation is something that Olympic Medical Center and hospitals across the state have tried to fix. But the high reimbursed states are New York, Florida, Texas, and California. And the low reimbursed states are Washington, Idaho, Montana, Oregon. So politically, it's been impossible. Certainly, I've tried for many decades to get Medicare rates fixed or get them more proportional, but it's just the style of medicine in Washington and the historical reimbursement levels just never quite correct, because they keep, they give everybody 3% raise. So it's been a challenge for a long time.
So it's essentially Washington state costs have gone up much faster than other states' costs have gone up?
No, I would say it's more like that Washington started off with lower costs, so therefore they got paid less. But Washington still has lower costs than other states. But you get lower reimbursement too. So it's particularly a challenge for high Medicare hospitals like Olympic Medical Center. When 60% of your business, you're only getting 80% of your costs. That is a economic challenge. Now I'm going to go into the major challenges facing hospitals. And there's no question there are big challenges. The biggest one, I think, is lower than cost reimbursed by Medicare, Medicaid, and other government payers. Like I said, Medicare pays about 80 cents for every dollar of cost. Medicaid is at 63% statewide. Other government payers like TRICARE, Labor and Industries, Veterans Administration maybe pay around 80%. So it's a challenge. I mean, one example is, let's say you were running a grocery store and the government passed a law that says for low income people, you have to sell $1 worth of groceries, where you spend $1 to get these groceries to them for 63 cents. And then the government passed a rule that said for everybody over 65, you have to sell $1 worth of groceries for 80 cents. And in order to stay open, you charge commercial $1.65. And beyond that, for low income people with no insurance, or people with high deductibles that have low income, you have to provide financial assistance, charity care, and you get paid $0. Yes, Colleen? Colleen, do you have a question? I can't see the chat, so maybe.
Sorry, I'm having internet instability on my end. So am I correct then that if one hospital charges twice as much as another hospital within the same state, Washington State, they will get the same reimbursement rate for that service from Medicare or Medicaid? Is that right?
Yes. Yeah,
Okay.
charges, what a hospital charges on Medicare and Medicaid really don't care. They pay their fixed amount. And commercial insurance, usually you have a negotiated contract. So charges, can be, really don't matter. Hospitals have to manage their costs and see how that compares to reimbursement. And the challenge hospitals face is on the revenue side, they kind of have a command economy. The legislature in Washington, D.C. and Olympia kind of tell them, the prices are set by the federal and state. So your revenue side is, at least for in Olympic Medical Center's case, 82% of it is fixed. But on the cost side, you have a free market. Hospitals are really price takers. You have to pay market for RNs, doctors, other workers, pharmaceuticals, supplies, electricity. So it's a big challenge to balance the equation, because you have a command economy on most of the revenue side and a free market on the expense side. And the state average for Medicare, Medicaid is somewhere between 60 and 75%, depending on the hospital. Now, Olympic Medical Center, I think, is over 80%. So that's a unique challenge because commercial obviously pays a lot more than government. So having more commercials is very beneficial.
So Eric, Bobby asked, could you please explain a bit about cost-based critical access hospitals? How are they different?
Yes. If you have 25 beds or less, like Forks Community Hospital and Jefferson Healthcare, both Medicare and Medicaid pay you costs, which is a big difference than a fixed reimbursement level. Not all your costs are paid at costs. Some of them are not. Not all services are, like skilled nursing beds that Forks Community Hospital, those are not paid at cost, but roughly critical access hospitals get about 90% of their costs from Medicare, Medicaid, which is a lot higher than the PPS hospitals that are about 80% from Medicare and 63% from Medicaid. So if you're a small hospital, it is there are advantages on reimbursement, for sure. Otherwise, most of them would not be open.
How many beds does OMC have? Daryl's on. He or Bobby probably could answer that, or John.
Yeah, I'd be making up a number, but I'd be close.
This is Daryl. If you can hear me, 67 currently.
Great. Thanks, Daryl. Thanks for joining us.
Yeah, I think Olympic Medical in Washington, D.C., they call Olympic Medical Center, it's called a tweener, which is kind of a weird name, but it's a tweener because it's too large to be critical access, so you can't get the cost reimbursed of being 25 beds or less. But you're too small to have the scale and commercial population that Seattle hospitals have. If you have 350 beds and 40% of your patients are commercial, That's a very different economic than if you're 67 beds with 82% of your patients government. So I will move on. Commercial insurers, there's big challenges with commercial insurance. They're paying slower than ever. Many commercial insurers take 90 days plus to pay bills, especially larger ones. There's lots of denials. Nationally, insurers deny about 15% of claims that are filed. Eventually, 90% of those get paid, but it's a lot of rework by hospitals. And then pre-authorizations, where you have to get services pre-authorized before you can provide them, can be quite a barrier, quite frustrating and time-consuming for physicians and their staff. So commercial insurers, they pay well, but there are lots of challenges in getting paid. Probably the biggest challenge out there beyond low reimbursement is workforce shortages. And workforce shortages are really across all jobs at hospitals, from physicians to RNs to technical positions, environmental service positions. There's just a huge shortage, and statewide hospitals employ about 120,000 people, and there's at least 12,000 openings posted. We think there'd be more than 12,000 openings if hospitals could hire. Particularly acute in RNs, technical positions like rad and lab techs. Physicians are in shortage, but just the shortage of workers is huge. And I showed you that income statement earlier. The cost of staffing hospitals in 2022 went up 1.8 billion compared to 2021. So hospitals spent a lot on raises and temporary labor, typically called travelers or locums. So the workforce shortages are intense. I will say the federal government froze the number of federally funded physician residency slots way back in 1998, and they kept it frozen until 2021, which created, we have a huge shortage of physicians. We're simply not training enough RNs across the state, and technical positions. But this is a major challenge. And I'll talk in my next slide about some of the things going on to fix it. But it's not going to be a short-term fix. Another big challenge hospitals have faced is inflation is greater than reimbursement. Inflation was hitting 8-9%. And the free market, if there's a shortage of something, the price goes up. And I think labor costs have gone up 8-10%, probably 20% over the last 2 years. And pharmaceutical companies, they're apparently for profit because they have definitely increased their rates aggressively. Supply shortages have increased rates. So obviously Medicare, Medicaid, Medicare has been giving about a 3% increase, which is well below inflation. Medicaid gave a 0% increase in 21 and 22. And commercial insurance, it depends on your contracts, but sometimes you sign multi-year. A hospital might sign a 3-year deal with an insurance company that gives them, 5% raises a year. And if inflation is 8 or 9%, then you wind up earning less off that contract. Difficult to discharge patients. This is when inpatients get stuck in hospitals because there's no safe place to discharge them. In Seattle, 5 to 10% of hospital beds are filled with these difficult to discharge. And this is like hundreds of beds, probably 300-400 beds are filled with these patients. It's not uncommon for people to stay in hospitals 3 months, 6 months, even more than 12 months. Olympic Medical Center faces this too. People get stuck in their hospital. There's no reimbursement. There's no place to send them. They're very costly to take care of, and they're occupying a bed that you need potentially for somebody else. But this is a huge issue across Washington. And we have way too many beds filled with people that shouldn't be in the hospital, but they're disabled or have other social issues, and there's just no way to discharge them. And the last issue I'll mention is just mental health and addiction issues. Society's problems show up in emergency departments and ICUs, and these tend to be high cost patients, growing volume. Reimbursement can be low, or they could be uninsured. So these issues really add to higher costs and financial challenges of hospitals. Okay, I only have one more slide, and then we'll open it up for questions. Some reason I can't get it to advance. Oh, well, there we go.
Oh, there it went.
Press the button harder. But the solutions, I think there's some good things happening. These financial challenges across the state. I think Olympic Medical Center's losses in 2022 were a little bit lower than state average. So these financial challenges, many hospitals are experiencing, and it's going to be challenging to fix. But I think we do have some direction and some positive things to talk about. Medicare and Medicaid funding. I think that the biggest good news is on Medicaid. House Bill 1850 was passed this last session this year, which gives substantial additional Medicaid funding. It's going to be about $1 billion of additional funding in 2024. It was a bill passed on a bipartisan basis. It passed the House 93-4 and the Senate 49-0. This additional Medicaid funding will bring the state average of Medicaid up to Medicare. So it'll be a little bit above 80 cents on the dollar. This additional $1 billion will really help hospitals. I will say a big thank you to Senator Vanderweg, Representatives Theringer and Chapman. On a bipartisan basis, they worked with Republicans and helped to get this bill passed, which will really benefit hospitals across the state and hospitals, in Clallam County and Jefferson County. Getting Medicaid reimbursement up was the biggest priority, and we were able to finally achieve that on a bipartisan basis, which I think was very positive. Now, Medicare is a different story. I think on Medicare, the best we can do is stop reimbursement cuts. And that's what we're working towards. I think there's multiple proposals on site neutral, which could affect SQUIM and reduce Olympic Medical Center's reimbursement. We're certainly fighting those, but our big goal on Medicare is stop the cuts and try to get the annual inflation increases rather than 2.8% to 3%. I think they need to be closer to actual inflation. On workforce shortages, there are some investments happening at the federal, state, and local level. I think Peninsula College is doing a great job, and I really like their direction in training more RNs and other healthcare workers. I think that'll be very important for Clallam County and Jefferson County in the coming years and decades. So locally, increasing training is key. Also, the state has made big investments on creating more RN training slots and other investments in the community college system. At the federal level, they did approve more residency slots. I think they created 5,000 residency slots. So they are making more investments. We're training people locally. The North Olympic Healthcare Network, along with Swedish and OMC, have that rural family practice residency program. I know Olympic Medical Center has an RN residency program. So training more people locally and making investments is going to be a big key to making sure we have the people to take care of our population. Trying to get reimbursement closer to inflation is a big challenge, but I think the big Medicaid increase that'll happen in 24 will help, and we're certainly advocating for Medicare to increase what they do as far as inflation increases. Difficult to discharge patients. The state of Washington made huge investments. About $500 million was invested in 2023 legislative session. This will help with patients moving out of acute care and into post-acute care delivery system. So that should make a difference in the coming years. And then behavioral health, of course, there's investments at the federal, state, and local level. I think Jamestown having the healing center for opioid addiction will be a big plus, is a big plus for our community. State is investing hundreds of millions of dollars in mental health and drug and alcohol addiction services. Federal level, there are some investments. So that's kind of the, there are some positive things happen, but it's going to be it's going to take some time to fix these financial challenges. And I'm going to stop sharing so I can see the chat. So that's my brief presentation. I'm sure it was very uplifting. Everybody is feeling so positive right now. The challenges are huge, but I think the mission is critical. Hospitals across the state serving their community is critically important work. And I think the good thing, I think rural healthcare is bipartisan. You know, when we go to Olympia or DC, we're talking to both parties, and both parties want rural hospitals to be, you know, be financially viable. I think rural hospitals do need the urban hospitals to have access to take critically ill patients quickly. So we're you know, all the hospitals and Washington State Hospital Association are working hard to kind of stabilize the economics in the coming. It's going to probably take a year or two to achieve that. I'm sure there are questions, and I may have missed questions in the chat.
Sure. Let's see. We've got, well, Julia made a comment, and I also wanted to see if either Daryl or John could share a bit specifically about OMC relative to Eric's larger painting that he provided for us that's statewide.
Oh, hi, this is Daryl. I don't want to, I know this is Eric's presentation and I'd be happy to speak in the future, but I mean, generally speaking, I think, you know, Eric's been around a long time and I think he painted the picture well. I wish OMC was exempt from some of these challenges, but we're not. And we're undergoing a financial turnaround plan right now. We're in the early stages of that because these aren't going to be solved quickly, and there'll be more outward facing communication here in the coming days and weeks, and I'd be happy to talk more. But in general, I appreciate Eric's perspective, and again, I wish we were I wish we weren't in this situation, and I wish the news was better, but I think he painted the picture quite well. So I'll pause there.
Thanks, Daryl. So we heard about the financial difficulties in the paper and such that OMC is having. Rebecca asks, can you please speak to OMC's vulnerability to being taken over by another system such as Franciscan?
I can jump in on that.
I cannot.
As a board member, the board has had a very strong focus for decades on remaining an independently owned and controlled medical center. You know, the decisions on what kind of care and how it's provided are best made here. And the last thing we want to see is for OMC to become a feeder hospital to a larger system where they cherry pick all the business they want and take it to the mothership. That's not good for us. It's not good for our community. More travel time for our patients would not be good. So you can never say never, but that is probably the last thing the board's going to be willing to accept.
Thanks, John.
Thanks, John. So a really good question a couple questions from Dale. Dale, do you want to ask? One's OMC directed and then general to Eric.
Sure. So the first question is, for the OMC folks, what are the top 3 barriers to recruiting staff that OMC is currently facing? And then an Eric question, does the answer to this question compare with other hospitals in the state?
Like, maybe I'll go first.
Go ahead,
I
Eric.
would say rural areas in general face some unique challenges. I mean, I think the biggest challenge is paying market compensation in recruiting is challenging when you have relatively very low reimbursement. You have less commercial patients, so other hospitals like large urbans and even critical access may have more funds to recruit. So Olympic Medical Center definitely faces challenges paying market wages. There's always the issues around trailing spouse. Doctors tend to have very educated spouses. Their employment is often a really big deal. And in rural areas, that can be challenging. Schools, I mean, doctors really value education. So continuing to invest in schools is important. And I would say, Olympic Medical Center, rural hospitals in general face these challenges that, it's easier for urban hospitals to pay market, to have access to spouse employment and have more school options. But Daryl or Bobby may want to add more about recruiting at OMC.
No, and those are definitely, that was great. And the other thing I would just say is, we've really realized the situation is what it is, and we've turned really internally. And I think Eric mentioned, some of the residency things that we've done here locally, clinical rotations with the college, and just trying to grow our own, realizing that our best workforce are in many aspects of our business is trying to train people that are already here. Housing, like it is most places, can be an issue for many. Childcare is an issue for many, and I know those are things that many of you on this call are involved with and working on. So, but the other thing we're really trying to do as an organization is we think, OMC is a great place and this is a great community, and really trying to focus on how do we sell it. We're never going to be the richest place, but how do we make this the right place, if that makes sense. So a lot of activity in that space around those issues as well. So, and thanks, Eric.
Yeah, I do think Clallam County has some advantages too. The water, the Olympic National Park, and it is a great place to raise a family. So there's advantages too. So Jim McIntyre, you have a question?
I do. And I just want to test my knowledge on an observation in response to, I think it was Rebecca's question or Pat McCauley's question about OMC being a takeover target. I may be wrong about this, but it just seems like with our particular payer mix here, we're not an attractive, from a cash flow standpoint, an attractive target for a corporate takeover. Because the payer mix isn't going to change, because the demographics are not going to change all that much over time. So that's just my observation. The other observation real quick is to the extent that costs are shifted to commercial insurance payers, that raises the cost of employment for local businesses and local governments, even OMC, to the extent that it pays healthcare insurance premium cost for its employees. That's impacted also. So it acts like a hidden tax. You can call it whatever you want to, but it shifts costs onto the local economy. And so it's very good to hear that the legislature might have realized that, in its policy deliberations about increasing Medicaid reimbursement rates, because those costs have got to get paid one way or another. So the question I had is, going back to one of your earlier slides, excuse me, is the patient census, it obviously dipped during COVID because of the limited shutdown of non-emergent care things and all that sort of thing. Has the patient load or the patient encounter number kind of gone back to pre-COVID levels? Because, you know, on a fee-for-service model, if you don't have a patient, you don't get paid.
Yeah.
But you have costs anyway. So how does that compare? And is there a correlation between the loss, economic losses, financial losses, and patient numbers?
Yeah, I can just speak to statewide. I don't really know locally, but statewide, I think inpatient and outpatient have returned to, you know, previous pandemic levels. In some areas, you know, things are actually higher than before the pandemic. You know, COVID's a new disease, so every inpatient we have that has COVID is a new inpatient that didn't happen before. There's also a lot of addiction and other serious illness in society. So inpatient work is up. I think outpatient is returning to normal. I think there's a shortage of physicians and outpatient services. So a lot of people are having trouble getting access. And speaking just a little bit about, you know, somebody taking over OMC. You know, OMC is a nonprofit governmental entity, so nobody can take it over. The board controls the entity, and some big corporation, even if they wanted to, they don't have that ability. And I think healthcare is best provided local. So OMC has done a great job for decades. And like John Nutter said, I think the board intent is to continue to do that. And I think you got a good point on cost shifting. It is a hidden tax. So Medicare, Medicaid should pay closer to costs. So commercial rates can be reasonable.
Yeah, and just real quick, Eric, Jim, your question. I mean, I would say the demand for services is higher or as high as it was pre-pandemic, and at least here locally, the limiter tends to be the amount of staff we have to care for those folks. So that's kind of a struggle that we have. But the demand has definitely returned, and we're doing as much as we can. And our census, average daily census. I know some people have asked me about, how do we maybe we just become a critical access hospital. The challenge is our average daily census is about 42 or 43. And that's a lot more than 25. And I think, we're not that rural to where a 25-bed hospital would make sense. At the end of the day, if that's the only way to survive, that's a different story, but we're not there yet. So I also wanted to mention that. Thank you.
Mm-hmm. Thanks, Daryl.
And critical access hospitals are not allowed to go above 25. And I'm sure OMC goes above 50 and 60 at times. So it's, that's a challenge.
Yeah, we were for just real quick. 2 weeks ago, we actually declared an internal triage situation because we were over capacity, and so was every other hospital that we normally transfer to for about 24 hours. So yeah, we still run up really high against that, and we have 15 extra beds we bought during COVID for overflow, and sometimes we even get into those. So 25 would be devastating, and we don't want to go there.
Got it. So are there certain departments that typically get a higher reimbursement rate, like say cancer care versus pediatrics, relative to the Medicare reimbursement and Medicaid reimbursement rates, or is it just kind of straight across the board?
I would say they're pretty consistently low. Some services are lower than others, but I don't think there's any, I can't think of any I think, yeah, I mean, I can't think of any service that initially has greatly enhanced reimbursement on Medicare, Medicaid. It's low everywhere for hospitals.
And it's the same everywhere in the state?
Well, it's the same for each type of hospital. I mean, critical access get costs, so they get paid differently based on their cost. For PPS hospitals, like Olympic Medical Center, the formula is the same, but they use a local wage index. So Olympic Medical Center actually gets paid less than the urban hospitals from Medicare because they have a higher wage index. But The formula is the same for all the different types of, for the same type of hospital. But Olympic Medical Center is in a difficult bucket because they're in the urban large hospital bucket. And they're the smallest, or one of the smallest in the state in that bucket. And I will say, I know Olympic Medical Center has financial challenges, but there are quite a few hospitals, even in more, have far greater financial difficulties. So it's challenging across the state.
So we've got known North Olympic Healthcare Network and Jamestown that as I understand it, their reimbursement rates are higher. Are there any services that could be moved to one of those that are particularly cost problematic for OMC? I guess that would be a Daryl question.
Well, and I can let Dr. Maxwell or talk, I know he's on this call, but I would just tell you that, they provide primary care, and we do about a third of the primary care in the community, which is around 16,000 patients on our panels. So, it's a significant thing. And again, maybe down the road, that's something we talk about, but I think, I believe that Dr. Maxwell and Jamestown would tell you, they have a lot of the same recruiting challenges we do. So it's not as if their workforce could grow, double in any short period of time. So it's a difficult thing because I think we're committed to those 16,000 patients, and to transition them in a positive way would take a lot of time and would be very difficult, I think, for all entities involved. So, but I don't know, I'll let Mike speak on that.
Yeah, thanks, Daryl. Yeah, that's you're spot on. Daryl and I have talked that if there's some way that we can help in some way that helps to remove some lower reimbursement headwinds that the hospital's facing, we're happy to do so. It's but all the challenges that Eric outlined and Daryl's talked about, we face as well. I mean, there's strong parallels, and so the reimbursement differential is only for a subset of our patients. It's not across the board, and the workforce challenges and the inflation impacts, recruitment, those are all big issues that we face as well. And so it's not there would be no magic bullet that we can offer, but certainly we're happy to talk and cooperate and help any way we could. But we're just focused on outpatient, and most of the, and Daryl can correct me, but most of the expenses are on the inpatient side, and that's something we can't help with.
So I just want to do a plug for Lefties game tonight. And then also next week, we're having the Department of Commerce on. They're going to be talking about childcare and all the programs that the state offers, and their experts, the CPAs that work on helping larger businesses do childcare in the workplace, that kind of thing. So they're going to be on next Wednesday. There's the ELF grant and all sorts of other things that they have, the subsidies that DCYF, Department of Children, Youth and Families, offers. So it's going to be kind of data wonky, but a lot of really good information for entities that are looking at potentially bringing childcare in-house or partnering with several other organizations for their own childcare resources. So with that, hey, Eric, thank you so much for joining us today. We're lucky to have you in the community and having you do all the work you do, a real partner. And so thank you so much for being here.
Yeah, maybe invite me back in a year and I'll have some great news to share, hopefully.
Great, absolutely. So, and if you'll send me the slides, I'll put them up on our website along with this recording.
Okay, yeah, Lori has the slides.
Okay, great. So with that, thanks everybody and have a terrific day. Enjoy the sunshine and come out to the Lefties game in Port Angeles. Bye-bye.
Take care.
Thank you.